Thank you for joining our webinar today. My name is Eleonora Folletto, and along with my colleagues here, we will be talking to you about building an economic case and planning for liver cancer control from research to advocacy today. And just a quick reminder that this session will be recorded. Before all else, I'd like to acknowledge the Australian Prevention Partnership Centre who supported this project and is funded by the NHMRC, Australian Government Department of Health, ACT Health, Cancer Council Australia, New South Wales Ministry of Health, Wellbeing SA, Tasmanian Department of Health and Vic Health. The Australian Government also contributed through the Medical Research Future Fund, and Queensland Health became a financial contributor in 2022. The Prevention Centre is administered by the Sachs Institute. The Australian Prevention Partnership Centre acknowledges the Aboriginal and Torres Strait Islander people as the first Australians and as traditional custodians of the lands where we live, learn and work. Personally, for me, I have the privilege of living and working on the lands of the Gadigal people of the Eora Nation, and I pay my respect to elders past, present and emerging. During today's webinar, we'll be showcasing the work we've been doing in liver cancer, both in the area of research and advocacy. By way of a brief introduction, I lead our gastrointestinal cancer policy and evaluation stream at the Daffodil Centre, which is a joint venture between the University of Sydney and Cancer Council New South Wales. Joining me today to talk about liver cancer control in Australia are Dr. Joaquim Worthington, also from the Daffodil Centre, Amanda McAtamney from Cancer Council Australia, and Carissa Feng from Cancer Council Victoria. This afternoon, Joel and I will be taking you through a project we recently completed. And then we will come together with Amanda and Carissa for a panel discussion. So please feel free to post any questions you might have as we're going through in the chat, and we'll come to them during the panel session. So liver disease and liver cancer aren't topics we hear about too often, but liver cancer is one of the most rapidly growing cancer types in Australia. You can see from this figure that has increased substantially in incidence and mortality over recent decades and is projected to increase further to 2044. Alongside these figures, we also know that survival rates are low at 22%. With statistics like these, our focus has been on both trying to understand more about the disease, but also what we can do to change the landscape in the future. In terms of understanding more, it's important to acknowledge the risk factors. The major lifestyle environmental risk factors of liver cancer are infection, especially chronic hepatitis infection, behavioral risk factors, especially excessive alcohol consumption, and metabolic factors, which include excessive body fatness and the metabolic syndrome, being of particular importance to liver cancer. Oh, excuse me. Also, the primary risk factor for liver cancer is liver cirrhosis, which is found in more than 80% of those diagnosed with hepatocellular carcinoma, or HCC, which is the most common form of liver cancer. For the purposes of today's webinar, we've taken a particular interest and a focus on the association between excessive alcohol consumption and excess body fatness and the progression to advanced liver disease in terms of alcohol-related liver disease and metabolic associated liver disease, then to cirrhosis and on to liver cancer. This is complex to break down, but understanding this pathway and development of liver cancer is critical when we try to determine what we can do and how we can intervene. So this leads us to considering what the right combination of interventions are that can either prevent liver cancer or detect it early when curative treatment is possible. In this space, the possible interventions in primary prevention that we considered are around weight management and alcohol cessation. In terms of secondary prevention or early detection, surveillance for people at high risk of liver cancer, or HCC surveillance, as we often call it, has been successfully used for ongoing monitoring of people with cirrhosis, as well as high risk groups with hepatitis B. And this detects early lesions or early stage tumours when this curative treatment is possible. Based on our current Australian guidelines, HCC surveillance of 6 monthly ultrasounds with or without alpha fetoprotein testing is recommended in high-risk groups. So understanding this, our Preventing Liver Cancer project, funded through the Prevention Centre, aimed to look at these combinations in more detail to determine what the economic case is for liver cancer and how we can plan for activities that will improve outcomes. More specifically, this particular project looked at excessive alcohol consumption and alcohol-related liver disease, excessive body fatness and the metabolic syndrome, and metabolic-associated fatty liver disease. And in stage 1, we assessed the recent evidence on changes in risk factor prevalence and the progression along this pathway to advanced liver disease and liver cancer. In stage 2, we use predictive modelling to provide estimates of the proportion of HCC or liver cancer deaths in Australia, which could be averted through these interventions. The project review and advisory team included Dr. Emily He, Professor Karen Canfeld, Paul Grogan, Megan Varlow, Georgia Carney, and Dr. Joachim Worthington, who I will now pass on to, and he'll go through stage 2 of the results in more detail. Thanks, Joa.
Thanks, Eleonora. So as Eleonora says, we wanted to capture the potential of both primary prevention, so weight loss and alcohol cessation, as well as secondary prevention in terms of surveillance on long-term liver cancer outcomes. And this is part of a case to be made for the benefits of liver cancer surveillance, which we need to weigh against the costs and resources required for future liver cancer control planning. Without being able to run a full randomized control trial, which can take decades, wait for the results, track all the costs for each patient, instead we use modeling to avoid having to run these large-scale trials and wait for the years or decades involved. So modeling is a big part of what we do at the Daffodil Centre. We do predictive modeling using what's known as the Policy One platform of models. So if you're working in this space, you may be familiar with some of these models, like Policy One Breast for breast cancer. We have cervical cancer models, colorectal cancer models, prostate cancer models, and many more. Primarily, these models are used to evaluate the potential impact of screening and surveillance for cancers and drive policy planning and decision making related to investment in these programs. So you may have heard of, for example, the planned lung screening program being established soon, as well as the colorectal cancer screening program, which we've done a lot of analysis of. And as Eleonora mentioned previously, we've informed the liver cancer guidelines, which we'll talk a bit more about later. So the modeling that we do is designed to capture this surveillance, and this was part of the design for what we call the Policy One liver model, which captures patients with liver disease at all relevant stages. For this project, that was metabolic associated or MAFLD HCC patients and alcohol-related or ARLD HCC patients, and we want to track these patients through their 4 stages of fibrosis, including cirrhosis, which is quite late-stage liver disease, liver decompensation events, undiagnosed liver cancers, as well as the eventual diagnosis, either through routine surveillance or asymptomatic or incidental diagnosis. For these patients, once their liver cancer is diagnosed, we model treatment. We model their 5-year survival based on their stage of diagnosis and their age, as well as modeling deaths according to other cause deaths according to patient age, sex, and liver disease status. Alongside this modeling of the health status of an individual, we also model all relevant costs, including the costs associated with cirrhosis care, cancer diagnosis, cancer treatment, costs associated with surveillance, and any end-of-life costs. Previously, we had developed an iteration of the model for the surveillance that Eleonora mentioned previously around modeling surveillance for high-risk patients, specifically patients with cirrhosis. So this project was an extension of that work to patients with earlier stage liver disease. So as I say, we focus on patients with MAFLD and ARLD, earlier stage liver disease, lower risk of developing HCC. And for these patients, the 6-monthly ultrasound recommendations for surveillance may not be appropriate, as they are unlikely to be developing liver cancer at these accelerated rates. So for these patients, we modeled a triage surveillance algorithm using less invasive technologies, such as a FIB4 blood test for liver function. This is illustrated here using this surveillance algorithm. So patients with a positive blood test result are then referred to an ultrasound twice a year. Patients with a negative blood test result are returned for another FIB4 blood test every 3 years. Part of the reason for this is because in Australia there's a really limited capacity for ultrasounds as well as a high cost. So sensible and cost-effective liver surveillance needs to limit the number of ultrasounds patients are required to undergo to limit both the costs and resource management as well as the burden for those patients. The algorithm we've depicted here is based on recommendations by the American Gastroenterological Association, the Asia Pacific Association for the Study of the Liver, and clinician advice from Dr. Emily He. And we know that similar algorithms are used by some gastroenterologists and clinicians in Australia, though this is mostly ad hoc and only by some clinicians. So using this model, we first evaluated the impact of this surveillance algorithm for patients with alcohol-related liver disease. And this routine surveillance means that patients can have their cancers detected at an earlier stage with a higher possibility of curative treatment. So illustrated on the right, we can see that without surveillance at the top there, only 33% of cancers would be detected at an early stage. So that's Barcelona stage 0 or A, indicated in green. And with surveillance, up to 62% of cancers could be detected at this early stage. And cancers detected at this early stage would have much higher survival rates due to the much broader options for curative treatment available for patients with early stage cancers. In terms of the population, this would translate to up to 108 HCC deaths that were caused by alcohol-related liver disease, potentially be preventable annually in Australia by 2045 if surveillance was rolled out from 2023, and that number would be sustained from 2045 onwards. This would come at additional costs of $11,800 per quality adjusted life year saved. This would indicate that it would be extremely cost effective, well below the $30,000 and $50,000 per life year saved thresholds often cited in Australia. A couple of notes around that is that this is the number of deaths which could be prevented through this routine surveillance algorithm. It doesn't capture the difficulty associated with such a program because this is surveillance for a very particular risk group. Unlike, for instance, the National Bowel Cancer Screening Program, a lot of efforts need to be made to make sure that the right groups are identified and targeted. Both identifying these patients and ensuring they're adherent to surveillance is a very difficult public health challenge. However, this sort of evidence demonstrates the value of surveillance for this group and can help with planning and investment in liver cancer control for patients with an alcohol dependency. Unfortunately, there's only limited evidence around the long-term impact of alcohol cessation for people with liver disease. Although there's a lot of evidence that it decreases liver disease risk in general, there's only really limited evidence on the long-term cancer risk for patients who have an alcohol dependency and then move to alcohol cessation. In the absence of this data, we modeled the overall all-cause mortality rate in alcohol-related liver disease patients based on the data that was available, and found that complete cessation would double the life expectancy of these patients from 8.6 quality adjusted life years to 17.1. And the evidence that is there suggests that routine surveillance wouldn't really be necessary in patients with long-term alcohol cessation, as fully abstinent patients are unlikely to have their liver disease progress any further to cancer, and in many cases will have their liver disease regress to a much safer stage, excepting those who already have developed cirrhosis who would be covered by the existing guidelines. Obviously, this is part of a broader context around alcohol cessation, and these modelling estimates would provide one small piece of the puzzle around the health benefits around alcohol control. So moving on to the other group of metabolic associated fatty liver disease patients. This primarily occurs in overweight and obese people, and similarly to the previous modelling, we found that routine surveillance using the algorithm would significantly increase the number of cancers being detected at early stages, therefore increasing their likelihood of curative treatment. But for this group, we also modeled the impact of weight loss. And due to the data limitations, this is in a very specific circumstance, we modeled the theoretical impacts of a one-off 10% weight loss for these patients. So the combination of a once-off 10% weight loss and routine surveillance would not only reduce the number of cancer cases by preventing people from developing cancer in the first place due to that weight loss, but also improve survival due to the impact of surveillance detecting cancers at an earlier stage. And the combination of these two prevention measures could mean that up to 150 MAFLD-related liver cancer deaths would be preventable through this combination. 150 would be preventable through surveillance alone annually in Australia. And with the combination of weight loss and surveillance, up to 485 would be preventable annually. It's likely that more cancer cases and deaths would be preventable through ongoing weight loss, but we don't have data to inform that modelling. And obviously there are other health benefits to weight loss, so these again need to be considered in a broader context. But this sort of modelling and the results relevant for liver cancer could help inform future approaches to planning around weight loss and around surveillance, like those seen in the National Obesity Strategy. However, there's a great deal of patients with MAFLD in Australia. MAFLD affects around 1 in 3 Australians at the moment, which is a huge proportion. And so surveillance can be very, very expensive for this group. For patients with early stage MAFLD who haven't developed fibrosis or have very early fibrosis, there's a really low risk of them developing liver cancer. So even with this surveillance algorithm, which uses relatively cheap blood testing at the early stages, it can be very, very expensive. So up to $160,000 per quality adjusted life year saved for people who don't yet have fibrosis, well above the thresholds of $30,000 or $50,000 per life year saved. And as the burden of MAFLD in Australia increases, this is going to be an increasing proportion of those patients who aren't necessarily going to see the benefits of surveillance. So these one-size-fits-all surveillance recommendations may not be appropriate. So this leads on to what we covered for our seeding grant. As part of this work, we needed to understand MAFLD patients and their risk profiles a bit better. And part of this was looking at patients with MAFLD and steatohepatitis, so a worsening form of liver disease. And patients with MAFLD and steatohepatitis are known as MASH patients. So MASH patients have a higher risk of having late-stage fibrosis compared to MAFLD patients, and therefore a higher risk of developing cirrhosis, so this late-stage liver disease, which is usually a precursor for liver cancer. And MASH patients are not only more likely to develop liver cancer, but they're more likely to develop it more quickly. So there's a greater need for liver surveillance in these populations. So with this in mind, we modeled the following approach to liver cancer surveillance using a triage test. So based on a patient's initial test, using either a FIB4 biomarker test or an ADAPT score, we referred patients with a negative test to have no further surveillance, and patients with a positive test were referred on to the surveillance routine we mentioned earlier, from 3 yearly biomarker testing up to 6 monthly ultrasound testing. In the real world, clinicians may update their surveillance recommendations based on a patient developing further symptoms. But for modeling purposes, this was used to separate people into those that do and do not receive this routine surveillance. So, as I said, for the surveillance recommendations for all MAFLD patients, it was unlikely to be cost effective, and we found a cost effectiveness ratio of $58,000 per quality adjusted life year saved. So that's the amount spent to extend someone's life by an extra year. This is above the willingness to pay thresholds, so it's more expensive than a government body would be willing to invest in most cases. But by introducing this triaging strategy to only send the higher risk patients to surveillance, we found that most of the benefits of surveillance could be achieved at much lower costs. So for instance, by stratifying patients with a blood biomarker testing and only sending the positive patients to ongoing surveillance, the cost effectiveness ratio would be reduced to $15,000 per life year saved, much more affordable and much more acceptable than the full 6 monthly ultrasound surveillance or the routine surveillance for all MAFLD patients. So this sort of triaging can retain all the health benefits of surveillance while reducing the amount of people that need to undergo surveillance without additional burden. This would also help manage the ultrasound burden generated by surveillance in Australia and ensure the efficiency of the system. So using this triage surveillance, up to 134 MAFLD or MASH-related HCC deaths could be prevented annually in Australia. This is almost as many as would be prevented without using this initial triaging step, and would significantly reduce both the costs and the burden for patients who would otherwise have to undergo this routine screening. And the different technologies used to triage these patients can be used to modify risk stratification to find a balance between the health outcomes and the resource demand, as well as the costs of surveillance. So this can be used to help inform planning for balanced and targeted care for high-risk patients. And back to you, Eleonora.
Thank you very much, Joa, and thank you very much for taking us through what was some quite complex modelling and showing us really what we've seen from the initial Preventing Liver Cancer project and also the additional seeding grant funding that Joa was successfully awarded through the Prevention Centre, is that we can make a difference in liver cancer outcomes. It's really about thinking about how these combinations of interventions can come together, but also how we get the right people into more specific HCC surveillance. So we're both using the health system and the services well, but also targeting the right people and ensuring the burden isn't too high. So the economic case really is strengthened when we're able to more systematically identify the right people to undergo surveillance. And there are certainly promising developments in this space that don't only come from this project. There is increasing interest and energy in liver disease and liver cancer control. And various agencies have been leading in this space. Just to nominate a few, ASHM, the Doherty Institute, Hepatitis Australia, the Liver Foundation, they've all done excellent work in this space. And from a cancer perspective, the Cancer Council Federation certainly has led a lot of recent activities. And I'm delighted to now include both Amanda and Carissa into our panel to talk a little bit more about what's been happening here. So along with Joa, we'd like to sort of talk through a couple of the more recent activities here. And please, again, feel free to add any questions that you might have in the chat. Just to briefly introduce both Amanda and Carissa, Amanda's the Manager of Public Health Policy at Cancer Council Australia. Her current portfolio of work focuses on the development and promotion of evidence-based cancer prevention, screening and early detection policy to the Australian Government and the wider community, and influencing the delivery of cancer control policy, research, treatment and care to reduce the impact of cancer in Australia. So I think you probably agree, perfectly placed to speak to this topic today. And Carissa is the Manager of Early Detection at Cancer Council Victoria. Her current portfolio focuses on developing strategies and advocating for policies that can reduce the burden of liver cancer on priority populations, such an important area, especially in liver cancer. And she's a research advisory group member with the WHO Collaborating Centre for Viral Hepatitis, a clinical advisory group member for Liverwell, and a member of the Victorian Hepatitis B Alliance. Carissa has an extensive experience working with priority population and prioritises an equity lens to her work in public health. So again, something that we haven't had a chance to sort of touch on in more detail, but perhaps it may come up in the questions now, is about how liver cancer does affect priority populations and how equity and using the equity lens is really an important topic for us to consider, or an important consideration in liver cancer control. So I I'll kick off the questions by perhaps asking Amanda if she could talk to how some of the recent work of Cancer Council Australia integrates with the work that we've presented today, and also with other plans, how that all comes together for liver cancer control. Thanks, Amanda.
Thanks, Eleonora, and good afternoon, everyone. Thank you for the opportunity to attend today and to share some of our recent work we've been doing at Cancer Council Australia. I do have a couple of slides that I will go through that just might help make it easy for people. To see what we're talking about. So we've recently launched the Roadmap to Liver Cancer Control. This has been a 4-year project funded by the Australian Government Department of Health and Aged Care, and it was a collaboration between Cancer Council Australia and the Daffodil Centre, led beautifully by Eleonora Folletto as well. So thank you, Eleonora, for your involvement. So the roadmap really aimed to establish a roadmap, a policy document to reduce the disease burden on the Australian community from liver cancer. And it provided strategic priority actions over the short, medium, and long term to reduce that burden. It was actually there were 2 key outcomes out of this project. So the development of our strategic roadmap and also the development of clinical practice guidelines for hepatocellular carcinoma surveillance in high-risk patients in Australia. And I'll pop the link to where you can access more information on those in the chat when I finish. So these outcomes really were achieved by incorporating best practice evidence on cost effectiveness and feasibility for enhanced liver cancer control and identifying those opportunities for practice improvement and policy reform. And we were really lucky to have some of the work that Joa has talked through around the cost modelling included in our roadmap priorities. We also really made an effort to ensure the focus for the future actions remained on those priority high-risk populations in terms of liver cancer. So in an Australian context, high-risk populations include Aboriginal and Torres Strait Islander people, those from culturally and linguistically diverse populations, and those living in remote areas. We also So we held a summit. Part of the policy process in developing the roadmap was around incorporating all the evidence that we could, but also we held a policy summit last year. We had over 50 stakeholders from across policy and advocacy, government. We had clinicians and other health workers, and it was really great to see, as Eleonora said, there's a strong interest in liver cancer prevention in Australia at the moment, so tapping into that. Some common considerations that we talked through in the summit that then informed the priorities for the roadmap was around intersection with other national strategies and plans. So as many of you would know, there are a number of national strategies in place at the moment that have either just been released, so the National Preventive Health Strategy, or are soon to be released any day now, including the Australian Cancer Plan and the Aboriginal and Torres Strait Islander Cancer Plan as well. So it was really important that those other plans and other national work that was occurring was forefront of our mind in developing the priority actions for our roadmap. There was also a strong focus on the intersection with hepatitis screening and testing and treatment, and ensuring that that was a focus for the priorities. And really importantly, thinking about that role of primary care and other health services. So looking at drug and alcohol services and including a focus there as well. Then really important, thinking about, well, they're all important, thinking about the access and availability of testing. So that was a really great slide, Joa, that you showed, the first modelling, it was, above the threshold of what any government agency would be prepared to pay. But then when you actually triaged it down, looking at what actually did make it more accessible and affordable, and thinking around capacity building for our health services as well. And underpinning all of that, I really think it's around cultural safety across all aspects of that cancer journey. So ensuring that those services that we're putting in place or that we're supporting adequately meet the needs of the community in the ways that those communities need it as well. So our final roadmap had 26 priority actions. And it really focuses on supporting prevention and early detection activities. So starting from infant vaccination around hepatitis, early detection, prevention of those risk factors, and Joa and Eleanor talked about those at the start of the presentation, and HCC surveillance as well through our clinical guidelines. So all of those will support improved liver cancer outcomes. And I won't talk through all of them for you, but this is what our priorities focused on. So they had a 2-year, a 5-year, and a 10-year time span, and that really aligned with the Australian Cancer Plan. So we wanted to match in, with the timeframes that they had in their plan to really leverage off any opportunities that we could. And I think the most importantly takeaway for everyone around the roadmap is it's really been designed as, I guess, the launch pad for increased activity in liver cancer. It's meant to be a platform that then supports clear calls for action and linking national policies that collectively we can leverage the impact, leverage our work and increase the impact on liver cancer control. So really, I think we all know that with the increasing incidence of liver cancer, if we don't do anything about it, it's only going to get worse. So hopefully with some of the actions and priority areas that we've identified in our roadmap, that will contribute to a reversal of the upward trend in liver cancer incidence and mortality that we're seeing. And as I said, I won't talk through those, but and I think just to end as well, to note that there is other work that we've included in the roadmap that's already existing. So leveraging off that work as well, particularly around research as well. So there's a lot of ongoing research in primary care that's occurring, and many of the members of the expert advisory group that led the roadmap and guidelines development are undertaking some of that research. So it's really important that we keep up to date on that progress to continue to inform best action related to interventions that we might want to implement.
Thanks, Amanda. I think it's really important for us to see that there's a framework that sits behind what we can do and helps guide the work that we've done and help show us what direction can be most helpful. You touched on hepatitis, and so I might ask Carissa if she would speak to, based on her background and her experience, I think she's very well placed to speak to hepatitis as a risk factor, and perhaps share with us some of the activities that Cancer Council Victoria have been doing in relation to hepatitis testing and treatment. Thanks, Carissa.
Sure. Thanks for that, Eleanor, and thanks for the opportunity to speak today. So besides Cancer Council Victoria's work in the risk factors for NCD space, we have also really prioritized working on the early detection and linkage to care for hepatitis B. After New South Wales, Victoria has the second highest number of people living with the hepatitis B virus. About 56,000 Victorians are living with Hep B. And the same locations in Victoria where there's a high incidence of Hep B are also the same locations where there is a very high incidence of liver cancer. Being born overseas in a hepatitis B endemic country is one of the key predictors and risk factors for hepatitis B, being a hepatitis B patient in Victoria. And so there's 2 projects that we are working on that have, really been informed by this data, as well as the priority areas that has been outlined in the roadmap. The first one is the roadmap talked about the importance of targeted education campaigns to raise awareness of liver cancer in at-risk groups. The Victorian government has funded Cancer Council Victoria to run an early detection campaign, which aimed to re-engage Victorians with health checkups and cancer screenings that were missed during the pandemic. Well, that campaign is mainly focused around the 3 main cancer screening programs. During the pandemic, there was also a drop in hepatitis B diagnosis and monitoring checkups. And that has flow-on impacts to what we're going to be probably seeing a later stage diagnosis of liver cancer in a few decades' time. So we've been leveraging, we will be leveraging the early detection campaign platform to also use that as a platform to encourage communities that are at risk of hepatitis B, such as the Mandarin-speaking community, to see their GPs for a hepatitis test or to resume regular monitoring as part of liver cancer control. The other priority area, which is on the slide, is around ensuring that there is linkage to care and monitoring post a hepatitis B diagnosis. So one of the priority areas in the roadmap is raising awareness of risk factors among community and healthcare professionals. Now, one of the gaps that we've noted in Victoria and across in the other states as well, as I mentioned, is that drop-off in regular monitoring. So, about 3/4 of people who have been diagnosed do not then go on to that regular monitoring and treatment. And we know that without regular monitoring and treatment, 1 in 4 people with hepatitis B will develop liver damage, and some might progress on to liver cancer. And so funded by the Department of Health in Victoria and in partnership with St. Vincent's Hospital here in Victoria, we've developed resources for healthcare workers to use with patients who have been diagnosed with Hep B, with really practical information on regular monitoring and treatment and the rationales behind that. And so these are currently being distributed and will be evaluated at the end of this year. So this is just a couple of examples. I'm really happy to pop some of those links in the chat later.
Oh, thanks, Carissa. I think that'd be really useful. I think it's really important what you've raised about both building awareness in community, but also working with healthcare practitioners, and in this case, in primary care, to really raise awareness. And so, Amanda, I'm wondering if I could come back to you and ask if you could speak to a little bit the stakeholder engagement process that was undertaken for the roadmap. You talked about the summit in a little bit more detail, and if you could talk about that process and how that might help us prepare for engaging in advocacy discussions. Thanks.
Thanks, Eleonora. So as I mentioned earlier, we did hold a summit, but I think before that, it's really important for everyone to know there was an expert advisory group that oversaw both the development of the clinical guidelines and the roadmap, and they were, we had 2 amazing co-chairs, Dr. Jacob George and Professor Jacob George, sorry, and Dr. Nicole Allard, and then underneath or next to that expert advisory group, we also had a community reference group, and they supported and participated in the work developing the guidelines and ensuring from their perspective of both community members and those with lived experience that it met their needs. And I think having those 2 functions there supporting the development of this work really did enhance the process and the outcomes. And I think they're probably the 2 of the most important stakeholders that were involved in this project. So as then I mentioned, we also did have the summit last year in September, and we had over 50 participants from a range of organisations and government departments, including NACCHO, so the National Aboriginal Community Controlled Health Organisation. We had representatives from GISA there, the Liver Foundation, jurisdictional health departments, and those amongst our Cancer Council Federation, and of course our expert advisory group and community reference group. And a couple of learnings, I guess, that I could share that might help others engaging or embarking on similar processes. I really think that we can achieve optimal public health outcomes when we have strong, genuine collaboration guiding a project. And I really do think this project was successful due to the sound guidance that we had from a range of experts, key stakeholders. We had researchers, clinicians, and those people from the community with lived experience from across Australia. And one of the key things that we learnt, so this is actually it took 4 years to conduct this project, but it really was meant to take about 2. So a couple of lessons learnt there, particularly around the impact of other priorities that might pop up, such as a COVID pandemic. So unfortunately, many of the people who are focused on liver cancer prevention do it as part of their role, particularly those working in infectious diseases. So we had a lot of the people involved early on in the project that really had to sort of pause pause that and focus, understandably, on supporting the COVID pandemic. So in hindsight, we perhaps may have been better off pausing the project and then picking it back up again last year or the year before, and that, you know, we would have achieved the same outcomes but in a bit less time. But we also really learned around identifying relevant stakeholders and involving them early on and building those good relationships. So many of the people that were involved in the summit that we held last year, we could have involved them earlier on, and I think enabling them to provide a couple of different processes of input might have helped strengthen relationships and just fed into the development of the roadmap a little bit better. But I think we got there in the end with a really amazing product that met a lot of stakeholder needs as well. So building in those opportunities for constant engagement and feedback and input from others. You know, we really can't develop things like this in isolation. So being, I guess, cognizant of what else is happening out there, and we do that through our stakeholder relationships. So that's a lesson learnt. And I think earlier on I spoke about all the other national strategies and policies that are in production at the moment or have recently been released. So definitely need to consider how the work that we're doing feeds into that, and considering different population groups and priorities, and then going back to our stakeholders and thinking who can support us getting access to that information is really important. Not one organisation can do this alone. I think particularly in liver cancer control, and the number of us here talking today really demonstrates that. So in terms of progressing the roadmap and how we can leverage those opportunities, we need to be getting GPs and clinicians on board, and things like the RSEGP Red Book, getting it out there. So using our stakeholder networks to really push and disseminate the roadmap and the guidelines as well, I think will support our advocacy going forward in this space. And really there's a need to engage with policymakers and researchers and health practitioners and clinicians and healthcare workers to improve health literacy and awareness and understanding of liver cancer control activities that can be implemented in all their various work that will help us achieve better outcomes. So hopefully some of those lessons learned are useful for others.
Thanks, Amanda. And Lucy has asked a question. First, she said, well, actually, second, she said, congratulations on the fabulous project, but I'll say that first. And then I'll come to her question, which is, in giving their advice, did you find that the different stakeholder groups tended to prioritise different things, or were they mostly aligned? Could you speak a bit more to the different perspectives and what type of advice was provided that you as researchers may not have considered otherwise?
Yeah, I'm happy to try and answer that one, and then Eleanor, jump in if you've got any points as well. So definitely, yes, a big yes. We got many different pieces of advice and priorities from different stakeholders, and I won't lie, it was tricky to manage sometimes. It's hard to say it's important to show people that their priority is really important and it is valued, and it's important to hear the diversity and the range of perspectives, but they can't all be priorities in the end. And it was really interesting in the summit, we did a little activity. We did a pre-survey and asked people across the spectrum of cancer control, so prevention, early detection, screening, through to end-of-life care and research as well, how people would prioritise where the priorities of the roadmap should be. And resoundingly, actually, most people said prevention and early detection. So that was really interesting too, that although people had very different perspectives in the finer detail, people could really see the most impact of this work would come out of prevention and early detection. And just going back to the second part of the question, what type of advice is provided that you may not have considered otherwise? Yeah, that's interesting. I think some of the lessons learnt that I just reflected on around involving stakeholders early and giving people multiple opportunities to have input and the iterations, which when you're trying to put something together and getting a larger group of people to provide input and reviewing is quite challenging. So yeah, perhaps we hadn't considered it from that perspective before.
Yeah, great. Thanks, Amanda. Yeah, my reflections, perhaps I have rose-colored glasses on now. I feel like that there were a lot of perspectives that were very similar, in the sense of uh, suggesting that prevention and early detection was the best area to focus on. So that from one angle did make our job a little bit easier. So, but it was a really interesting process, and yeah, having more time would have been excellent as well. So we've mentioned.
Oh,
Oh,
sorry,
sorry. Go
sorry,
ahead,
Eleanor. One more thing I just thought of too.
please.
Some of the advice that we had from our community group was really prominent and really important that we did end up applying particularly to the guidelines, and that was around addressing cultural sensitivity and safety, and how to ensure that the priorities we're including in the guidelines and the roadmap really didn't contribute to further marginalisation or add to the sort of discrimination that might already be occurring in that space. So that was something that we definitely then on reflection had to go back to ensure we incorporated that in a meaningful way. So that was really useful perspective and guidance that we received.
Yeah, definitely. Thank you, Amanda. We've talked about research a bit and how important researchers are, and I will admit I am biased, but I totally agree with that statement. So, Joe, I just wanted to ask you a question as well about, in terms of research, what additional research might be needed to help guide decision making and continue to build this economic case for liver cancer outcomes in the future.
Yeah, so from a health economic point of view, I think it's certainly at a point now where a lot of the research is coalescing, and we're seeing modeling groups from other countries looking at questions in this area with a similar sort of lens and coming to similar conclusions. I think a lot of the attention will be on improving our understanding of the costs, and improving our understanding um, of the high-risk patients. In particular, speaking about thinking of the seeding grant work that we did to identify the potential benefits for MASH patients, a big part of that was about the evaluating the different technologies available to triage patients. And that's an area where there's been a lot of new technologies emerging over the last few years. New scores, for instance, that combine different technologies into one overall score to stratify patient risk. And that's the sort of thing where they're currently at the stage of an RCT, but haven't necessarily been put in an economic context and applied to the Australian setting and thought about how those will translate to population level outcomes, whether it's worth the investment in it, who should be tested with these sort of strategies. So I think there's a lot of emerging research to be done around those biomarker technologies and similar technologies. I think that'll be a really interesting area to watch out for over the next few years.
Yeah, great. Thank you, Joa. And Carissa, coming back to you, from your perspective in the Victorian context, how does all of this come together, and how can this information be used for advocacy at the state level, and how might you be thinking about that, and what advice might you have for other people in other states? Big question, sorry.
I'll try my best. I think no doubt all governments, across Australia are currently operating on extremely tight fiscal climates, and health systems are asked to do more with less. Maintain quality, achieve equity in health outcomes, find the savings. We've got the lung cancer screening program that's just been added onto the list. We're talking about liver surveillance. So there is quite a lot that's coming at them in this really tightening climate. So, the information presented today and the roadmap, we've kind of used it in Victoria in three main ways. And the first is, really, for the first time, we're able to really elevate the urgency of liver cancer and give us a policy platform to work from. It helps us to be able to knock on doors, revisit conversations that we've been having with government and other stakeholders to say, well, we now have evidence on what should be prioritized to address the rising rates of liver cancer. And that kind of brings us down to that kind of the question about prioritization. Lucy, as you have alluded to, liver cancer is a fascinating area because it has so many different etiologies, so many different risk factors, so many different priority groups, and each with different pathways, with different barriers to participation, to adherence to the early detection and testing pathways. So I think this information, and particularly the roadmap, really helps us to hone in on what evidence and experts and those with a lived experience say we should prioritize to achieve value for those that are going to be most impacted by liver cancer. We then apply that kind of Victorian lens on it, and we look at these priority areas and this evidence based on our unique epidemiology and kind of what our demographics is saying. So, we've got a very high a multicultural population. Compared to other states, we don't have as much of a kind of rural spread. So, the way that the priority areas that we're going to be focusing on will be slightly different. And then it kind of brings me down to then the third point, which is leveraging the opportunities that already exist within the state. So we've been kind of going through, all this information, and we're overlaying it with what existing programs and infrastructure already exists in Victoria that we can leverage in the short term to reduce the liver cancer burden. So are there existing programs, infrastructure, campaigns, policies, or workforce capacity that we can kind of reorientate and leverage for liver cancer control? So these are all steps that I think policy advocates can do while operating in this really challenging budgetary climate. Looking at your data, looking at your demographics, really honing in on what are the kind of risk factors and etiologies that you want to prioritize in your state, and the infrastructure that you can then leverage for that to happen.
Yeah, great, Carissa. I think that's an excellent message about leveraging what we can do. I think your work before talks about using working with general practice and primary care, and we know that that's a very overburdened sector. So working out how that can integrate in a reasonable way is really important. Thank you very much. So if you have any final questions, please do pop them in the chat, but I might ask our panel to answer one final question, just with a key learning perhaps from your work in liver cancer that you think might be helpful for others when they're building an economic case for this sort of liver cancer or in another particular disease area. So Amanda, I might start with you with maybe just like your nugget that you want to leave the group with.
Thanks, Eleonora. So I think it's really important for us to take a holistic approach. While the economics are really powerful on their own, they're not powerful enough because they don't. We need sector buy-in. We need to get those people who have lived experience, and they're really powerful stories of those people who have been affected by liver cancer, who can really frame their situation and what action might need. That then underpins the economic case to get us in the door with those who can make big decisions. So it's really important that we have the modelling and the cost effectiveness, and alongside that we need to include lived experience and sector buy-in and have those policy priorities there as a big package. So I think working together is really important.
Great. Thanks, Amanda. Joa, from your perspective?
Yeah, I just wanted to sort of echo something Carissa alluded to earlier of there's the thing that's become increasingly clear and is borne out in the modelling is that the same solutions won't necessarily work for the same groups. The three biggest risk factors are people with viral hepatitis, people with alcohol dependencies, and people with metabolic syndrome, particularly overweight and obese people. And the solutions and future for those three groups look dramatically different, right? So for people with hepatitis, the rise of antivirals, for instance, is very different to, for instance, the way we would approach people with metabolic associated fatty liver disease, where it's about this long-term weight loss. And the different approaches that need to be taken for these groups really require thinking both from the bottom up in terms of the individuals that would be affected, but also from the top down in terms of what does this look like at a population level. So for instance, I mentioned for MAFRD-related patients, even though that's a group that's growing and will soon probably be the majority of HCC cases in Australia, it's only a small proportion of people affected by obesity. So targeting people within these groups and making sure that you're not sort of trying to make a one-size-fits-all approach work for everyone is going to be really key to making sure that this is effective, and that will have to be a marriage of the modelling and sort of the boots on the ground understanding of patient needs.
Yeah, great. Thank you, Joa. And Carissa, any final learnings that you'd like to share with the group?
I think, the liver cancer and hepatitis space, it's one that is just shrouded in so much stigma and discrimination and institutional racism, that where, oftentimes access and adherence is an issue because it has got so many layers of complexity behind it. And an example of the level of stigma, in this area is we tried to get, a resource co-designed, and we actually found it incredibly challenging, despite paying people, to get them to be part of a focus group. People, said, definitely not. I do not want anyone to know that I've got liver cancer or I'm living with hepatitis B. And it's intergenerational trauma. People who have who've watched family members die from liver cancer are the same people who've got hepatitis B or are living with liver cancer themselves. So I think we just, as researchers, as policy advocates, we need to be mindful of, the backstory. That there is a face to every statistic. There is a face, and there is a life, and there's a whole family history. And when it comes to liver cancer and it comes to hepatitis, it's intergenerational family histories. So, kind of bringing that lived experience and bringing that into the co-design process and into our advocacy and research is really important, not just for, advancing this in Australia, but also to bring dignity to the people who are most impacted by this.
Thanks, Carissa. I think that's a really important and really thought-provoking point to leave us on. And just with that, I'd like to thank all of you for joining us today, and also our presenters and our panel members for really sharing their understanding and knowledge of liver cancer. I hope we've been able to impart with you a little bit of knowledge, as well as a bit of understanding about how difficult it can be in this particular area, but that we continue to work and we continue to strive to improve outcomes for all Australians. So thank you very much, and have a lovely afternoon.